Good afternoon, everyone. Uh, thanks for attending our AYR. I play young rheumatologist the second webinar in 2021. I'm Julian Zhao from Peking Uni Medical College Hospital, Beijing, China. I'm the vice chairman of the AYR, and today I'm the moderator. And let me introduce my partner, the co-moderator, Dr. Lydia Tan. She comes from Hong Kong. She also the member of the AYR. Hi.
Hello, everybody. So
Please
many
introduce.
Excuse me.
Okay.
Hello, I'm Dr. Lydia Tam from Hong Kong. Today, we are honored to have Professor Helmut Prosch to talk to us on the topic of CT thorax reading and CTD ILD. Many connective tissue diseases are associated with interstitial lung disease, so this would be a very useful workshop for us to learn the skills. Professor Helmut Prosch is an associate professor of the radiology and section chief of thoracic imaging at the Department of Biomedical Imaging and Image-Guided Therapy of the Medical University of Vienna. He obtained his medical degree in year 2000 from the University of Vienna. Professor Prosch was trained in radiology at the Otto Wagner Hospital in Vienna, Austria. He also worked as a research fellow at the Children's Center Research Institute in Vienna. His research focuses on diagnosis and staging of lung cancer and deep learning for the diagnosis of diffuse parenchymal lung diseases. Prof. Prosch has published more than 100 articles, reviews, and book chapters. Today's session is going to be an interactive one, so everyone please be active and vote during the poll session, and feel free to raise hands and ask questions at the Q&A box. Without further ado, let's welcome Professor Prosch.
Thank you very much. I don't know if there are more introductions to be made to your colleagues. No? Okay, then I start off. Thank you very much. Thank you very much for having me. It's a great pleasure being here. And this is meant to be a basic introduction into HRCT for rheumatologists. And as I expect quite a variety of knowledge, previous knowledge from your side, it has to be, I have to start quite from the beginning at the basics. And as we move on, the cases will become more tricky, but it still will stay at a more basic level, just to make that clear from the beginning. And I'd like to invite all of you to join this, to ask you questions that you might have. And if you have a question you would like to ask me directly, just raise your hand, press that button, and then we will address you and you can ask your question. So with that, having said that, we move on. And I'd like to give an outline what I'm planning to do. So in this talk, you will gain a basic understanding on HRCT findings in connective tissue disease, ILDs. I will focus primarily on scleroderma and on rheumatoid arthritis. If we have enough time, we can also move then further on to dermatomyositis and findings there, because they're quite different there. But the focus still will be on the most basic findings there. In this talk, you will also understand the indications for imaging for CTD ILD patients. And last but not least, you should appreciate the importance of multidisciplinary discussions, as in many cases, the diagnoses are not as straightforward as you might get the impression in this presentation, because it will show you simple cases, but I can assure you on a daily basis, the challenges are quite there, and it's not always as easy as it might look like. Before we move into cases, let's just fix some or refresh your knowledge on CT. So why do we need HRCT first in the first place? And this is a series of images taken from the same patients. These are just reconstructions at a different slide thickness, ranging from 8 millimeters down to 1.25 millimeters. And as you can see, with the thick slices here on the left side with the 8 millimeters, you appreciate that there is something going on in the lung parenchyma, but it's really hard, if not impossible, to delineate the anatomical structures which are involved and to describe these findings appropriately. And as you move on to thinner sections, you will appreciate here that this is not a reticulum, these are not reticulations, these are these dots you see here. That's what we radiologists would call a nodular pattern, and it's almost impossible to tell this based on the 8mm slices. And I tell that because I see this time and again also here in Austria, and then in CT scans I get for second opinion from other countries, that frequently radiologists tend to perform thin section CTs. And if you see that and if you get that, in many cases we have to repeat the scan. So it's important to start right off with the appropriate imaging technique. What about HRCT as a term? And HRCT, the classical term of HRCT, refers to a CT examination which was performed or was invented back in the 80s of the last century. Back in the days, the scanners there were not able to scan a whole body in the few seconds we are doing right now, but they had to perform slice after slice to cool down the system. And in order to make thin section CTs possible, they defined that in order to investigate patients with a diffuse parenchymal lung disease, it suffices if you are taking just a limited number of sections of a lung. So there are these thin sections, but taken in 2-centimeter intervals. That's what was done back then. But no, doing that, you just were able to image around 5% of the lung volume. There's another option to scan in 1-centimeter intervals, but still, there's a lot of space in between slices, and you're just able to scan about 10% of the lung volume. But this is what you call HRCT. Still, if you are ordering HRCT, this might what you get back. But what's the better option nowadays is to perform a volume CT. And the volume CTs are just normal CTs we are doing right now, which can be done in each and every CT scanner, which is available right now. We are scanning the whole body or just the whole lung in 1mm thick slices. And this gives us the possibility to get the whole volume information and reconstruct images in any plane we would like to see. And this is helpful because in particular in the diffuse parenchymal lung diseases, the distribution and the relation of findings towards other structures is important to delineate. And if you just look at these axial slices, and that's what we call an axial slice here or transversal slice, you might miss or get misled in regard to the extent of findings or to the distribution of findings. And if you are reconstructing images in these multi-planar views, as you see here, there's a coronal plane, there's a sagittal plane, you're much better able to delineate the distribution of these findings. You see here clearly that there's a predominance of the upper lobe here, and the basal parts are almost spared. So that's one thing. So HRCT, we don't call this now HRCT anymore. We call it thin section CT in order to avoid confusion. But if you may order an HRCT if you are in your center, and it might be possible that you get back these CT scans with a 1-centimeter interval, which is not good for diffuse parenchymal lung diseases, as there are a number of problems associated with that, and I will get into more detail later on in my talk. So that's the CT scan we are performing in deep inspiration, in sustained deep inspiration. But then there is also another technique we are using, at least in our center and many other centers as well, for patients who come to us for the first time. And there we perform an additional series in sustained expiration. And in deep inspiration, you see that the lung is very dark because it contains a lot of air. And if you perform an expiratory scan, you see that the density of the air is the lung parenchyma much denser, because most of the air, or a lot of air, already left the lung parenchyma. But as you can see here, there are certain areas which remain dark. And this is due to the fact that the small airways leading to these areas are narrowed, and thus air can't leave these small areas as it should. And this gives us information also on small airways. You have to know that the small airways, which are airways with a diameter of around 1 millimeter or somewhat thicker, they are below the resolution of HRCT or thin section CT. And if you want to know more about a potential narrowing of these small airways, we perform these exploratory scans. And there you see these areas which remain dark. And this means that small airways that are involved. And this is a patient, sorry about that, a patient with Sjogren's syndrome. And what this scan tells us that there's also an involvement of small airways, indicating that there might be also a follicular bronchiolitis involved, as this is a typical finding there. So that's why we perform this first examination in all patients who are presenting with a diffuse bronchial lung disease. And then there's another thing you should know what we are doing from time to time. We don't do this on a routine basis in our center, but some do that as well. In some patients, you see these reticular abnormalities here in the basal part of the lung. And I will come back to that later in my workshop. These are the areas where I would expect to see findings in scleroderma, or also in other diffuse bronchial lung diseases. However, there's another explanation for these findings, and this is so-called dependent the gravitational effect. As you know, there's also a hydrostatic effect in the lung parenchyma, and if a patient is lying for a longer time on his back, you may see an increase in density in the dorsal part of the lung, and this may give you the impression that there's a pathological process going on. And in order to get a clarification on that, you just put the patient in prone position, meaning you put the patient on belly, and as you can see here in the patient, this patient, there's a complete disappearance of these findings in the dorsal parts of the lung. This is now the dorsal part here. See here the vertebral spine. The vertebral spine. The patient is lying on the back, and you see that these findings are gone now. So this was just due to the gravitational effect. We call this hypostasis in the radiological lingo. So that's also a third examination you may see in patients performing HRCT. Okay, so a few words, and then I end my talk, my introduction on technical background is about radiation dose, because there are sometimes concerns, in particular from colleagues from internal medicine, about radiation dose. And this concern is justified still, but this concern dates back to the days when CT scans were associated with a substantial radiation dose, like 7 millisieverts per scan. And you have to know that the natural background, at least here in Austria and in the US, is around 3 millisieverts. So with one CT scan, patients got a equivalent of 2.5 years, roughly, of background radiation dose, which is substantial. But nowadays, with our modern CT scanners, CT scans can be performed with a much lower radiation dose. So this is what we call a low dose CT scan with a radiation dose of certainly less than 3 millisieverts, and with even more modern scans, which we do perform just to screen for abnormalities, we can be in the range of 3 or 5 chest radiographs, so very, very low radiation dose. So, and it's not to be expected that you see any damage to DNA with these very low radiation doses. So don't be too much afraid, too concerned about radiation dose. The information gained by CT is much more important than the risk associated with CT. But again, you should avoid repeated CT scans, as this adds up the applied radiation dose over time. Okay, if there are any questions, just post them in the Q&A box, and if not, I will move on. So the topic today are the interstitial lung diseases seen in connective tissue diseases. However, they are not an isolated entity. They are in this context of diffuse bronchial lung diseases, or interstitial lung diseases, as they are also called. And there are so many of these. In fact, there are more than 200 of these diseases, and so the differential diagnosis there becomes quite challenging at times. And in order to help us with our structure and an understanding of these diseases, there are a number of classifications out there. This is one which is frequently seen in the literature, subdividing these diseases into 4 groups: the ILDs with known cause, the idiopathic interstitial pneumonias, the granulomatous interstitial diseases, and then the other interstitial lung diseases. And your diseases, meaning diseases seen in connective tissue diseases, are found in this group of ILDs with known cause, connective tissue diseases, but also asbestosis is there, drug-induced lung toxicity, vasculitis associated ILDs, hypersensitivity pneumonia, and there are even more certainly. Then there's this big and important group of idiopathic interstitial pneumonias, and the most prominent disease here is idiopathic pulmonary fibrosis. And I have to point that out because this is the disease with the worst prognosis, and this is also the reason why pulmonologists focus their attention primarily on this disease. So whenever we see in our daily life with the pulmonologist a fibrosing lung disease, we have to clarify if this could be idiopathic pulmonary fibrosis, because the median survival there is very small. It's around 3 years without therapy. And then there's also idiopathic NSIP, and NSIP is one of the most common patterns we see also in connective tissue diseases. And this gives us the overlap with the idiopathic interstitial pneumonias. And this is also then the overlap of 2 specialties, rheumatology and pulmonology, as we see it in our daily life. And then I make the story short. There's granulomatous diseases and other ILDs. I don't want to bother you too much with these entities. In our daily life, at least from a radiological point of view, there are not that many. Most common ones are the idiopathic pulmonary fibrosis, again, the one with the worst prognosis. Then we have these connective tissue diseases and hypersensitivity pneumonia. These are the 4 big players, the 3 big players. And from a radiological point of view, hypersensitivity pneumonia is the most challenging one because it may present with a variety of CT manifestations. It may look exactly like a connective tissue disease, or may exactly like look like an idiopathic pulmonary fibrosis. And on the other hand, also patients with connective tissue diseases may present with hypersensitivity pneumonia. So whenever I see a CT scan from a patient with a connective tissue disease, I also have to consider hypersensitivity pneumonia as an underlying disease. And then there's other diseases like sarcoidosis, pneumoconiosis, and other diseases. But my focus today will be primarily here. But the problem there is an overlap with other diseases as well. And I will come to that point back again. Okay, so what we will discuss today are fibrosing lung diseases. And before we move into that, just a few words, what is lung fibrosis? Because you need an understanding of that in order to understand what we see on a CT scan. Lung fibrosis is primarily just a scarring of lung tissue, and it is the consequence of chronic or repetitive injury of lung tissue. And it is seen in idiopathic form or in the context of systemic diseases, allergic reactions, name it. Problem is that it may progress and then lead to an increase in mortality. And this is a histological slide here of a normal lung parenchyma. As you see here, this is the scarring of the lung tissue. Okay, so from a pathological point of view, there are primarily 2 types of fibrosing lung disease. So these are big players, and one is triggered primarily by inflammation. Inflammation meaning triggered by autoimmune diseases, hypersensitivity pneumonia, or drug exposure. And this leads to a chronic interstitial inflammation with quite a uniform fibrosis. So what the pathologists see in different places of the lung is always the same pathology. So it's quite a uniform disease, and that's what pathologists are calling the non-specific interstitial pneumonia. This is also seen as a part of the pathological context in hypersensitivity pneumonia. So this is an important reaction pattern of lung tissue. And then there's another type of fibrosing lung diseases, which is caused by repeated injury, like tobacco smoking or occupational exposure, air pollution, and together with accelerated epithelial aging. this may lead to another form, a pathological form of lung fibrosis we are calling the usual interstitial pneumonia. And it looks different from a pathological point of view than the NSIP pattern. So these are these two groups of fibrosing lung diseases we see primarily. There's certainly more, but these are the big players, real big players. One thing I did not mention so far, also inflammation may ultimately lead to a UIP pattern. So in your disease, in your patient groups, you primarily see either non-specific interstitial pneumonia, but you also may see this UIP pattern. But both of these patterns may be seen also in other contexts, in the idiopathic form or caused by other diseases. And this is why the diagnosis of these diseases are primarily based on the combination of information we are getting from the clinical evaluation, meaning history and symptoms and lab findings, with the CT findings. And we combine this information in a multidisciplinary discussion to come up with a working diagnosis or a diagnosis. And this multidisciplinary discussion is frequently just a telephone call or a brief discussion on the floor in the ward, but this is important to come up with different ideas to discuss whether or not a biopsy is necessary. Biopsies are usually not done because they are risky at times, but they are done primarily in cases in which the CT scan is inconclusive or there's a discordance between clinical and imaging findings. So CT plays quite a central role here. And in order to come up with a very narrow differential diagnosis, which then in turn helps you to come up with a final diagnosis, we have to analyze these CT scans in a systematic way, because just by looking at these CT scans, they look quite the same or quite similar. And you need to analyze them systematically, otherwise you won't be able to come up with a good differential diagnosis. And this is usually a three-step approach. We first look at the CT pattern, we then look at ancillary findings, and last but not least, we look at the distribution. And this should at the end give us a disease pattern. And this is the starting point then for our discussion. Sometimes we need also additional criteria as radiologists, but we will focus today on the CT pattern, the ancillary findings, and the distribution. Let's get started with the CT pattern. And to understand what we radiologists mean with that term CT pattern, we just have to understand what CT does. CT measures the density of lung parenchyma. And the density of lung parenchyma is determined by the content of air primarily. And as you see here in this histology slide, lung parenchyma consists primarily of air. And only to a limited degree, there is lung parenchyma and there are vessels. So this darkness of the lung parenchyma is determined by the content of air primarily, and any change in the content of air will change the density as displayed on the CT scan. And if there is a destruction of lung parenchyma, meaning there's more air, then we talk about a reduced lung density. And this is an example here. I will not go much into detail here, but that's emphysema. If you look closely here, this is getting here very, very dark as compared to the surrounding lung parenchyma. This is due to the fact that there's a destruction of lung parenchyma, thus less lung parenchyma and more air. But then there is also the possibility that you see less air as air is displaced for some reason. We'll get to that. And this is what we call an increase in lung density, and there it can be either subtle, as you can see here, there's only a partial displacement of air, so there's still air within lung parenchyma, and this is what we call ground glass, and this is the main pattern we discuss in fibrosing lung diseases. And then there are also consolidations, which are seen in many, many diseases, starting with pneumonia, cancer, but also in diseases which are seen in your daily life, like in vasculitis, or also in organized pneumonia in the context of dermatomyositis. So when talking now about these changes in density, we radiologists have to structure that, and we do that by defining 4 groups of patterns. And the most common one is the increase in lung density, and mentioned that already ground glass consolidation. And if this increase in density is associated with a loss of volume, we call it atelectasis. Then there is also the possibility that this increase in density is very, very focal. We call it a nodular pattern, or gives us the impression of crisscrossing line. We call it a linear reticular abnormality. And last but not least, we may see a destruction of lung parenchyma in the context of emphysema or cysts or cavities. That's also something we may observe. But these are the four groups and four terms we are using as radiologists. These are defined in the literature, and that's what radiologists should do, to have a uniform language. But today we will focus primarily on fibrosing lung diseases. And when it comes to fibrosing lung diseases, there are two patterns primarily we see. One is ground glass and one is reticulation. Let's stay a little bit here with ground glass. If we look here, this is a patient with a connective tissue disease. And you see here that there's an increase in lung density. And I can tell you that this is an increase in lung density because this is normal lung parenchyma. And if you look here at the gray scale of this parenchyma, it's almost the same as the content of these small airways. So this dot here is an artery, and next to it, this ring here, that's a small airway. And the content of the small airway is almost as dark as the surrounding lung parenchyma. So this is normal lung parenchyma, but this here is way too gray. And this is, but still what we see here is vessels. So we see an increase in density with a preserved visibility of small airways and airway walls and vessels. And that's what we call ground glass. That's just a definition. On the other hand side, there is this reticular abnormalities with these crisscrossing lines. You see here also you get the impression the lung architecture is distorted. These vessels here, these lines here are vessels. They don't run as straight as you might expect in lung parenchyma. Importantly, ground glass is a helpful finding because if you see ground glass in the context of a fibrosing lung disease, you have a good reason to believe that there's an inflammation which triggered that. So it doesn't mean that what you see here is inflammation, but it is a good sign that this is an inflammatory trigger which led to this fibrosing lung disease. Reticular abnormalities, on the other hand side, are completely non-specific, and they don't help you that much for the differential diagnosis. But there's one thing which needs to be mentioned here. Ground glass in and of itself is not describing neither inflammation nor fibrosis. These are two patients here. One patient has a connective tissue disease. The other one has a reversible inflammatory disease. And just by the looks of it, it's not possible to discriminate that. And here is the answer. This is pneumocystis jirovecii pneumonia, completely reversible fungal pneumonia. And in fact, this pathology is primarily seen in the alveolar spaces, whereas here this is non-specific interstitial pneumonia in a patient immediately prior to lung transplantation, a few days prior to lung transplantation. This is an interstitial process, but it gives you just the impression of reticular abnormality of ground glass. So ground glass itself should raise the suspicion that you're dealing with a fibrosing lung disease, but that's not enough. You have to do more. And the same, but not in the same extent, holds true for reticular abnormalities. This is a patient who presented with acute symptoms at our ER. And if you look here at the CT scan, you might get the impression that this is a fibrosing lung disease. However, as this patient was presenting with acute symptoms, we were a little bit cautious because this is a patient with undergoing a chemotherapy. And here is the follow-up of this patient, and you see a complete resolution of these reticular abnormalities. So reticular abnormalities, although they are more frequently due to a fibrosing lung disease than ground glass, can still be due to a reversible process. So ground glass reticulation should raise the suspicion that you're dealing with a fibrosing lung disease, but you need to look for more, and this more are the ancillary findings. And the ancillary findings are secondary to this loss of volume. I mentioned already, the fibrosing lung diseases are scarring of lung tissue, and scarring is always associated with a loss of volume. And we see that also in imaging. We see that on a chest radiograph. I don't know how familiar you are with chest radiographs, but here the diaphragms are not in the position they should be. They should be here at this level. Yeah. So there's a loss of volume here. And in combination with these reticular abnormalities, you can assume that there's a shrinking process going on. Also in the CT scan, we see that, and we see in CT scan even better these so-called traction bronchiectases. This is a bronchus running here from the hilar region towards the periphery, and this should narrow as it runs towards the periphery. And as you see here in this patient, it doesn't narrow, and it has also this varicose appearance. And this is what we call traction bronchiectasis. Importantly, the lung parenchyma surrounding this bronchi has to be altered as well, because then you can only know that this is a fibrosing lung disease if the surrounding lung parenchyma does also fit to a fibrosing lung disease. And then there's a other sign. This is honeycombing, which are these multi-layered cystic spaces. Neighboring cysts are sharing their walls. This is the real proof of fibrosis. This is a term you have to know if you're reading your reports from a radiologist. If they are mentioning honeycombing, you know, okay, this is a fibrosing lung disease. Okay, so let's start off and let's see what you learned so far. And the question to you is now, which kind of pattern do you see here in this patient? And I think that's question set 2. So if we could start please the polling now with question 2. I hope it works. I don't see it.
Yeah, we didn't see the question. Sorry for Stephen.
Okay, but I get also some great answers from the audience already using the Q&A. And you are right. Yeah, this is ground glass. You see here, there's an increase in lung density. This is normal lung parenchyma here. See these white dots. These are the vessels, and you see here these gray areas. This is ground glass. And if you look closely here, you see also that these bronchi here in the periphery, you see them here, and you should not be able to see them here that far in the periphery. They are enlarged. So there's a good reason to believe that this is a fibrosing lung disease. Okay, let's move on to this case here. What do you see here? That's a completely different disease. Okay. Question said 1 would be great, 2 would be great, but if it doesn't work, no problem. Okay, I don't see it. Let me see. Okay, some of you are now here in favor of reticular abnormalities. If you see here, these lines here, some might say that this is reticular. However, this is not representative. So whenever we ask for the pattern, we go for the predominant pattern. We need to describe this. I wouldn't describe this as a reticulation. I would describe this as band-like consolidation and not as reticulation. But what we see here is an increase in density, quite homogeneous. That's us again, what we call ground glass. But putting now these two CT scans next to each other, what makes them different? Because in both of the situations, in both patients, we see ground glass as the predominant pattern. In both of the patients, we see traction bronchiectasis as a sign of fibrosis. But these are two completely different diseases. So what makes them different just by looking at the CT scan? Distribution, yes, exactly. I get completely right answers here. The distribution makes a difference. And that's how our differential diagnosis works in radiology. We look at the patterns to get an impression that this could be fibrosis. Whenever we get this impression by seeing reticulation or ground glass, we look for signs of fibrosis, meaning loss of volume, traction bronchiectasis, and honeycombing. And then we look at the distribution to run our differential diagnosis. That's the whole thing about differential diagnosis in CT. It's always the same pattern, and serial findings, distribution. So having said that, look here at this case here. That's a young patient, a 42-year-old female patient with systemic sclerosis and Raynaud syndrome. And if you look here at the lung function tests, the volumes here are completely normal. And I don't know about your region, but in Austria, at least, that's all about a a office-based radiologist does usually. They just get the volumes in lung function test. They don't perform a DLCO. The DLCO stands for diffusion capacity for carbon monoxide. And also in this patient, the DLCO is only slightly limited. Okay, slightly reduced. So the colleagues performed the chest radiograph. And what about this chest radiograph? Is that normal? Yes or no? Probably start. We try again with the question set. The first question set. Oh, now it works. So let's try that. Let's answer. Is that normal? Yes or no? Just vote now. I think you can. Okay, yeah, most of you are in favor. That's no. And yes, this is a nice question, because this is what I call a bias. So if I tell you that I will show you a case with a fibrosing lung disease, and I show you an image, you will say, okay, there's something going on. But if you show this to a radiologist, I'm very sure that most, if not all of the radiologists will tell you there's nothing going on. It's a completely normal chest radiograph. You see an increase in density from the chest, from the top to the bottom here on the chest radiograph, but this is primarily to this increase in density in the absorption due to the breast tissue. But if you look at the lateral, you see there's nothing going on here. This is normal. Okay, so this shows you one thing: chest radiographs probably are not the best tool. The best tool to analyze patients with a connective tissue disease or a suspicion of connective tissue disease in the lung parenchyma is CT. This is the same patient. This is the same patient. And yeah, I think I don't have to ask you now what we see here, because I think that based on the answers I got so far, you know how to analyze, to identify ground glass. This is ground glass here. There's an increase in lung density. You still see vessels. So by definition, this is ground glass. Then the next thing we do is we look for signs of fibrosis, because ground glass in and of itself is not necessarily a fibrosing lung disease. If you show me this, let me show you here. If it would show me this here nowadays in a patient coming in with acute symptoms, I would have the suspicion that this is COVID-19. So in and of itself, ground glass is nice, but not diagnostic. So it just raises the suspicion of fibrosis. So now looking here for signs of fibrosis, I have troubles identifying traction bronchiectasis. Probably here in the lung periphery, I don't know. Here my screen is very small. In the lung periphery, you see also some slightly enlarged bronchi. However, knowing that this patient has no acute symptoms and knowing that this patient has a connective tissue disease, I have every right to call this a fibrosing lung disease. Okay, how much reversibility is there? I don't know. Yeah, I always get this question from my pulmonologist: is this a reversible process? Yes or no? And honestly, in most of the cases, this is not reversible. However, I can't really tell you or can't exclude that some of these regions might be just inflammation. But knowing from experience, talking from experience, most of these findings are not reversible. You sometimes see that the lung parenchyma becomes looks better in the follow-ups, but then if you look closely, you see that the former gray areas become more gray as they retract, and just the rest of the lung parenchyma becomes better aerated. So, but in effect, what you see here is primarily fibrosis and not inflammation. Okay, and now our differential diagnosis is based on the distribution. And if you look here at the distribution in this case, I assume that most of you will say, okay, there is a basal predominance here. I see here these findings in the predominance. If you go again up here, this looks like normal lung parenchyma. Look here at the trachea, and the lung parenchyma is almost as dark as the trachea, the content of the trachea. So that's normal. And going down, this changes, and the lung parenchyma becomes darker. So this is ground glass with a basal and peripheral predominance. And this is by definition what we call a NSIP pattern. This is, from a radiological point, a non-specific interstitial pneumonia pattern in the appropriate clinical context. And I have to stress that out again and again. This is only in the appropriate clinical context. If you show me a patient with these findings, similar findings, or these findings with acute symptoms, this could be COVID-19, this could be many other diseases as well. So it has to be seen in the appropriate clinical context, but in this context here, the diagnosis is non-specific interstitial pneumonia, and you do not need to perform a biopsy because the predictive value of that CT finding is quite high. So what we see, and I have follow my structure here as well. We see as a CT pattern ground glass opacities and to a certain degree reticular abnormalities. And we see this associated with a loss of volume and traction bronchiectasis and the distribution, that's important, distribution makes a differential diagnosis is primarily in a basal and subpleural predominance. There's a question coming in from you. Since there is no traction bronchiectasis, why isn't it called, why it's called fibrotic? And that's a great question. And here in this context, I can only I say that this is fibrosis because I know the context. This is a patient coming in with no acute symptoms, with a connective tissue disease. So this is presumably a fibrosing lung disease. And based on the distribution, the diagnosis here would be NSIP. Someone raised his or her hand, so please. Could these two colleagues be, the first colleague be unmuted and then the second one? No? There are a couple of people raising their hands, so it would be great if they could ask their questions. Hello, where is my technical support here? Hello, because I don't know if I can do that. Let me see if
yes,
I can
but nobody is talking. They are being.
Oh, they're just raising their hands and not talking. Okay, so that's probably a misconception. So if you press on the hand button, this is should indicate that you would like to talk. Okay, then there are other questions coming in here. Dilated pulmonary vessels. Yes, there are. We notice also from other studies that also the pulmonary vessel gets enlarged, but this is hard to judge on just on a visual basis. So visually, that's really hard to determine. It's easier to determine an enlargement of bronchi than the enlargement of vessels. We have special software to determine also the enlargement of vessels, but on a visual basis, that's very subjective. That's why we don't include this in our differential diagnosis in the pathway. Should a prone CT scan made for this basal ground glass opacity? Great question, because I raised that point early on. But going back to the CT scan, you will appreciate here that you see this ground glass opacity is not only in the dorsal parts, but also in the ventral parts here. So this can't be just due to a gravitational effect. So that's why we don't perform I don't perform a repeat scan in the prone position. Then there's a question, can vessels seen suggest vasculitis? No, also in patients with known vasculitis, the resolution of CT scan does not suffice to diagnose vasculitis. We do this in an indirect way by looking at the additional findings, in particular the distribution of ground glass there, but this would go too far today. I won't talk about about vasculitis. How to differentiate cellular and fibrotic NSIP? That's another important question, and the answer is we can't do this on a CT basis. CT has not the resolution, as of now at least, to discriminate ground glass caused by inflammation from ground glass caused by fibrosis. So what we do, and I'm sure you do as well, when you first see a patient with a fibrosing lung disease, they get an immunosuppression suppressive therapy, and we if it works, it works, but in most cases you don't see much of a striking effect on ground glass. So it's usually it is a very fine reticulation, fine fibrosis with low resolution of CT scan, so you can't discriminate that. There's another question, what is meant by subpleural sparing? I will come to that in a second. Thank you for raising that question. Hurricane artifacts. I don't know about that. I never heard about that term, so I can't really answer that one. Is that if there is reticulation with traction cactuses and minimal ground glass, how do we differentiate whether it's probable UIP or phlerotic NSIP? Great question. I hope we have enough time to get to the answer there. I have the answer prepared already, but it would go too far to answer it right now. Lymphadenopathy in ILD, it is quite commonly seen. So if you see a lymphadenopathy, don't you worry too much about differential diagnosis unless you see a very prominent lymphadenopathy. So if you see a prominent lymphadenopathy, you should consider also sarcoidosis. Sarcoidosis is an important differential diagnosis also for these diseases, but in this case, I would not be concerned too much about sarcoidosis, but you may also see lymphadenopathy in NSIP. There's one caveat. In patients with Sjögren's syndrome, you know that there's an association with lymphoma. So we see a very prominent lymphadenopathy in patients with Sjögren's. I would be concerned that this could be a malignancy, and we go from there as well and biopsy that. I once received a report that mentioned crazy paving pattern. It's also consistent with ILD. Okay, thank you for raising that point. The crazy paving is defined as a combination of ground glass and a superimposed reticular pattern. And this is very non-specific. Some would even call this here crazy paving. I wouldn't, but you could. And in and of itself, it's not a diagnostic feature. It is seen in many diseases causing ground glass. It's also seen in a particular disease called alveolar proteinosis, but this is very rare and is not in the focus of today's talk. And okay, the last question I answered right now, and then we will move on, is when should you do a lung biopsy? I perform a lung biopsy, or we perform a lung biopsy if there is a discordance between the clinical findings and the imaging findings. So in this case, this is a patient with a connective tissue disease, has no smoking history, no signs of a hypersensitivity pneumonia, and everything fits with an NSIP based on CT, and everything based on the same fits to the same diagnosis with from a clinical point of view. That's why you would not biopsy. Okay, this is a beginner case. I have also a couple of cases showing that this is not always the way to go. So if there is a reason that you doubt the diagnosis, you should go for a biopsy. Maybe someday we will have time to discuss these cases as well, because this would go too far for today's talk. So let me stop there and we move on here because I see we are running out of time and then there's so much more to discuss. A colleague asked about the subpleural sparing, and this is what we call the subpleural sparing. See here, that's a patient with an NSIP as well. It's somewhat denser than the case before, but that shouldn't bother us too much. And you see here that there's a sparing of the subpleural space. See here, this is the chest wall here. There's a dark line separating the chest wall from the altered lung parenchyma. That's what we call a subpleural sparing. That's either a absolute sparing of the subpleural space or just a relative sparing, that's so meaning that it's not as much involved as the rest of the lung parenchyma. That's what we call subpleural sparing, and this is a very common finding in NSIP. One thing which needs to be mentioned, because this gets then into this differential diagnosis versus the usual interstitial pneumonia without honeycombing, is that the extent of reticulation is quite variable in NSIP. In most of the cases, you see either just ground glass or a combination of ground glass and reticulation. However, there are also cases in whom you see just reticulation, as in this case here. And in these cases, the differential diagnosis becomes much more challenging because this then would also include other differentials like the usual interstitial pneumonia pattern as discussed before. Okay. So let's move on to this case. And I see there are more questions which are more for an advanced class, but this today is basically for beginners. So please excuse if I can't go into the more difficult question, as this would require a much more discussion. One question came in with, do you perform core biopsies or FNA? And both we don't. In the context of connective tissue diseases, of diffuse parenchymal lung diseases, neither core biopsy nor fine needle aspiration biopsies suffice. There are two options to biopsy these patients. One is the so-called cryobiopsy, which is done by a bronchoscopy. You put in a probe to the lung periphery, cool it down to -80 degrees, pull it out, and then you get samples which are a few millimeters in size. Or you perform a surgical lung biopsy. Usually it's done via video-assisted thoracic surgery. Okay, so let's move on to this case here. That's a 52-year-old male patient with a systemic, I think there's a female, I prepared this case yesterday, but I think it doesn't matter. With no systemic sclerosis and a shortness of breath. And she has no known allergies and non-smoker. You see there's a combination that she has clearly 70. You see this prepared yesterday, it was too fast. But you see here the lung function is impaired, but not too bad. It's just still okay, but DLCO is significantly reduced. So let's go to the case and let's look at the CT pictures here. And this looks quite different from what I told you before. And I'd like to ask you first, but then in order to give you an impression, I walk through the pictures. And now I'd like to ask question set number 2, I think it was, with the different CT patterns. So which CT pattern would you describe here? Could you start this polling number, set number 2? Yes, that's exactly the right one. Well, that's a great group. Most of you are voting. It's not the normal I see here. That's great. Okay. Perfect. So I think you can stop here. And most of you, wait a second, most of you were in favor of honeycombing, and you are absolutely right here. This is what we see here. What we see here are these multi-layered cystic spaces, and you see here that the neighboring cysts are sharing their walls. And this is what we call honeycombing in the radiological lingo. And what this honeycombing tells us is just that this is an overt fibrosis. And you see this honeycombing as the effect of this cyst. This is from the same patient. You see this air-containing cysts, and neighboring cysts are sharing their walls. And this is the effect of overt and gross fibrosis, and develops out of these areas of reticulation. And this reminded someone of the honeycombs of bees, and that's why we call this the honeycombing pattern. And this is a proof of fibrosis. I mentioned already loss of volume and traction bronchiectasis as a sign of fibrosis. However, they are not that easy to determine in many cases. So the real proof of fibrosis is honeycombing. And this is primarily seen in the context of UIP, the usual interstitial pneumonia, and fibrotic hypersensitivity pneumonia, and sometimes also in these unclassifiable fibrosing lung diseases, but we are focusing today on the first one, the usual interstitial pneumonia, because that's a CT pattern you see quite frequently in patients with connective tissue diseases. And this is characterized by these reticular abnormalities in combination with honeycombing. And I have to stress this out again here, distribution makes difference. And the difference here is the distribution in UIP is a basal distribution, basal and peripheral distribution of honeycombing. I mentioned in the slide before that honeycombing can also be seen in the context of hypersensitivity pneumonia, and this is why these are the definitions from the ATS and ERS and Fleischmann Society as well. You have to exclude additional criteria which would point primarily towards hypersensitivity pneumonia. I won't get into detail here, but tiny nodules and air trapping, you will see that to a significant extent, this would point towards a hypersensitivity pneumonia. But if all 4 of these points are fulfilled, you do not need to perform a biopsy no matter what, because biopsy will reveal UIP. So that's why this typical findings of a UIP is so important. However, it doesn't tell us the reason for UIP. The most common reason for UIP is idiopathic pulmonary fibrosis, the one with a very bad prognosis. And then it's seen also in rheumatoid arthritis, scleroderma, hypersensitivity pneumonia, familial pulmonary fibrosis, and other diseases. And importantly, this is something we see quite often in patients with rheumatoid arthritis, this progression, and many of patients with rheumatoid arthritis show an IPF-like progression. And the risk factor, a risk prognostic factor for progression is the presence of honeycombing. The problem is that these patterns are not helpful when it comes to determining the underlying rheumatological disease. So if you see a UIP pattern, this is in most of the cases caused by rheumatoid arthritis, but it's seen also in other connective tissue diseases. And the same holds true for NSIP. You see NSIP also in rheumatoid arthritis, but you see it in very commonly in systemic sclerosis. Organizing pneumonia, I did not mention so far, is also a common feature in connective tissue diseases. If I see a combination of NSIP and organizing pneumonia, I always consider dermatomyositis as the underlying disease. So that is an important point here. Can honeycombing occur in fibrotic NSIP is a question which was raised by a colleague, and the answer is yes, you may see that. Usually we see the honeycombing there not in a presentation, but during the course of the disease, and it's not as extensive as in the UIP pattern, but you may see that. And in some cases, and in more advanced patients with a more advanced fibrotic NSIP, it then may also look like a UIP pattern. That's absolutely right. Moving on here, I should explain reticular abnormalities. I will do that in a second. UIP and NSFP have baseline subpro distribution, so the difference lies in the difference lies in ground glass versus honeycombing. That's correct. So if you see just ground glass in the basal and peripheral predominance in the context of a connective tissue disease, again, the context is important. You are safe to call this NSIP. If you see honeycombing in the basal and subperipheral predominance and no signs of another disease, then you call this the UIP pattern. What is organizing pneumonia? There's so many questions, I can't answer them, all of them today, I'm afraid. Let's stick here with the topic at hand. When a CTD ILD is suspected and we want to do a CT scan, is a specific request we need to do. The important thing is you have to tell the radiologist or the technician that you're dealing with a connective tissue disease, and they will apply the protocols they have in their centers. Usually perform a non-contrast enhanced thin section CT scan, but this may vary from center to center how they manage that. Then, okay, the question in regard to tuberculosis. Tuberculosis is quite, it looks quite different from connective tissue diseases. So this is usually not a big problem for the differential diagnosis. In the TB findings are usually seen in the upper lobes, at least the post-primary TB, and the findings seen in connective tissue diseases are primarily seen in the basal parts of the lung. There was again, just going back here, the reticular abnormalities are shown here again for the colleague who asked about the reticular abnormalities. You see here, this is normal lung parenchyma. And you see here, all these lines, there's this crisscrossing lines here in the lung periphery. You see here, this is a bronchus, this is traction bronchiectasis. This is reticular abnormality, reticular abnormalities, whereas in ground glass, you see this homogeneous increase in lung density. Okay, there's one question about scoring, and I think I just continue answering your question. in regard to scoring of ground glass in patients with connective tissue diseases to determine prognosis. And we know that this is important because in patients with limited disease, you have a much better prognosis than in patients with extensive disease. And limited disease meaning less than 20%, to put it simple. And to do that, that's not rocket science. You just look at the CT scan, and there's this proposal from the group from the Brompton Hospital with these 5 predefined sections, one section at the level of the subaortic vessels, one at the level of the carina, one at the level of the veins, pulmonary veins, one at the diaphragm, and one in between. These predefined sections, and for each and every section, you just estimate the extent of ground glass. So there's ground glass here, there's ground glass there, it's about 5%. If you move down, there's more. I don't want to go into detail here because that would cost too much time. But you add up the estimated percentages for each and every slide, these 5 slides, you add them up and divide by 5, and then you have the extent of disease. Okay. Okay, I think as so many of you asked the question in regard to organizing pneumonia, I skip. Oh, wait, before I do that, let's get to this case here, 2 more cases. And I think then we have much more to discuss. So this is a patient, again, with a signs of a connective tissue disease. And I don't want to go into detail here. We have to stop finishing time, I was told. But looking at the CT scan, let's go and poll again, because this is important here. I walk through the pictures, and then I'd like you to ask, I'd like to ask you to answer poll number 2, poll set number 2 again, please. Could you please start that? Yeah, this one here. What is the predominant pattern here in this patient? Okay, let's stop here. Okay, the majority of you are in favor of reticular abnormalities, and that's completely right. What we see here is not ground glass, because there's no homogeneous increase in lung density. We see all these lines here. You see here, these are lines here in the lung periphery, and particularly here, they're crisscrossing, but there are no clearly defined cysts. So this is what we call reticular abnormalities. And this is seen here in a basal and peripheral predominance. And I mentioned already in my introduction that reticular abnormalities are very, very nonspecific. In the context of a connective tissue disease, this could be NSIP, this could be UIP. And then it could also be hypersensitivity pneumonia. So we are really lost there. So what we do according to the guidelines, the worst situation here, from a prognostic point of view, the worst pathological process seen here would be UIP. And that's why we call this a probable UIP pattern if we see reticular abnormalities and traction bronchiectasis as a sign of fibrosis in a basal and subpleural predominance. So if you see that, this could be UIP, this could be NSIP, this could be hypersensitivity pneumonia. So in the next step, and I will not get into details here, we exclude hypersensitivity pneumonia as good as it gets. And if this is fulfilled, this is what we call the probable UIP pattern. Probable UIP pattern means that I excluded hypersensitivity pneumonia from a radiological point of view, but I'm still left over with a differential diagnosis of the UIP and NSIP. In the context of connective tissue diseases, this is not that much of a problem because treatment does not differ between NSIP and UIP for connective tissue diseases. However, when it comes to idiopathic diseases, this is a problem because UIP has a much worse prognosis than NSIP. And for this reason, in an idiopathic context, we look at the age distribution. If patients are older than 56 or so, the probability of IPF is super high and the probability of NSIP is pretty low. But in younger patients, there's an overlap of probabilities. And this is why for younger patients, we should go for a biopsy if there is no sign of a connective tissue disease. That has to be stressed out again. So that's why these guidelines from the Fleishman Society state that if you see this probably UIP pattern, again, particular abnormalities in a basal predominance associated with traction characteristics, patient is older than 60, a current or former smoker, because these are the risk factors for idiopathic pulmonary fibrosis, and no history of other potential causes of fibrosis, meaning no systemic disease, then you can diagnose this UIP pattern without a biopsy. In all the other cases, you should go for a biopsy. So this should answer the question some of you had before, how to run the differential diagnosis here. And then there were questions in regard to the organized pneumonia. That's quite a common problem also for rheumatologists. Just to give you an example here, that's a 66-year-old male patient with shivering fever. Also, she presents like a pneumonia. And that's not that rare in this context. We see this time and again, a couple of times a year, that patients presenting initially like a pneumonia. They get also sometimes treated like that. And this is the chest radiograph, and the radiologist there diagnosed pneumonia. Yeah, you can question that because it's bilateral, it's peripheral, but still that's quite an okay diagnosis. However, after 1 month of therapy, there was no change. And the diagnosis here is organizing pneumonia. And let me show you the initial CT scan, just to give you an impression of what we see here. And now I ask you, what do you see here? As question set number 2, please. Just start polling number 2, please. Okay. Question set, yes, please. What do you see here? What is the predominant pattern? Oh, you're so good. That's great. Okay, then I can stop here because most of you are absolutely correct. That what I see here are consolidations. There's an increase in density. I don't see any vessels, so that's consolidation. And this is seen here in the context also with some reticulation, but not that much. And again, like with all the other fibrosing lung diseases or other diseases, we look at the distribution and you see here a clear basal and peripheral distribution of these findings. And this is what fulfills the criteria of organizing pneumonia. In organizing pneumonia, you see here these usually quite symmetric, you see that on both sides, band-like consolidations, frequently with positive aerobronchograms. You see here, these are the airflow bronchi, and you see also these peribronchial consolidations. These consolidations run towards the hilum, and you see a dilatation of bronchi, but that's usually quite reversible. And this is again important. Peripheral subpleural sparing is also seen here, as you can see here. There are areas with a subpleural sparing in a basal predominance. And you see again, the distribution is so important in radiology. And this is a typical UIP pattern. And UIP, organizing pneumonia pattern. Organizing pneumonia can be easily explained. Each and every day, our lung parenchyma is injured. And this injury here is repaired by a mechanism called organization. But in some situations, this can be idiopathic or in the context of a disease, you see an overshooting of this repair mechanism, leading to a filling up of the alveolar spaces with this repair granulomatous tissue. So the lung architecture is preserved, but the alveolar spaces are filled up with this granulomatous tissue. And this is, again, the consequence of a non-specific response to lung injury, and can be seen to collagen as a connective tissue diseases, which is a very common cause of this organizing pneumonia. In the context of infections, can be drug-induced or idiopathic. And the problem is it presents frequently with flu-like symptoms, and this is the reason why so many patients get a treatment for pneumonia first. And this usually has quite a good response to steroids. However, you have to treat patients for quite a long time. And this is also the pattern, again, this combination of organizing pneumonia and NSIP is something we frequently see in dermatomyositis, polymyositis. If I see a patient, whenever I see a patient with something that looks like organizing pneumonia with or without NSIP, I always write in my report, please send this patient to rheumatology, because in so many cases, this is due to a dermatomyositis, polymyositis, or a antisynthetase syndrome. We see this quite often nowadays, as this is now pretty well defined, either as a antisynthetase syndrome or anti-MDA5. This is quite common and quite progressive, and a disease which requires our special attention. That's why it's important to raise this fast, this possibility. So, time for answering questions. Isn't it important to differentiate between UIP and NSIP? Because NSIP is more responsive to steroids in connective tissue diseases. Yes, but the data is not there. Yeah, there's the assumption that this is true, but I pointed out earlier that also in NSIP, we are not able to discriminate inflammation from fibrosis based on CT. And the studies in scleroderma there are not that many good and large studies in scleroderma. One large study is the study on nintedanib in patients with scleroderma, but there the percentage of patients with UIP was too small to determine if there was any significant difference between these two groups. So we don't know simply. Does organizing pneumonia occur with an infection, acutely early disease, or long-term sequelae? The answer is it occurs quite soon. Also infection leads to a injury of lung tissue, and injury gets repaired using this repair mechanism. But sometimes you see this quite for a prolonged time, and this is exactly what we see nowadays in COVID-19. In some patients, we see organizing pneumonia following COVID-19 for months. And this is also something which is confusing at times nowadays, because COVID may also lead to an increase in autoantibodies, and sometimes it's not. It raises the question whether or not it's an autoimmune disease or a consequence of COVID-19. Okay, I can't get into the vasculitis questions. We don't have enough time today. And also IgG4 is 2 for advanced pH. There's so many questions with okay. Let me see the questions which are more basic for today. I think I answered the most basic questions already. I'm sorry I could not get into details in many regards today, because this was meant to be a basic course. There's so many other diseases you rheumatologists are treating. I did not touch on LIP, the lymphoid interstitial pneumonia. I did not touch on vasculitis. I did not touch on sarcoidosis, but this was meant to be a basic course for a basic understanding of the CT patterns we see in connective tissue diseases. Yeah, one thing is, the last question I think is, can you tell between methotrexate-induced pneumonitis and rheumatoid disease, hypersensitivity versus NSIP or organizing pneumonia? So methotrexate-induced lung toxicity usually is a acute hypersensitivity pneumonia. And this is something you can diagnose quite well. Probably we have time for another, when we can meet another time, I have more cases on that as well. The hypersensitivity is something you see as a response to methotrexate therapy. The diagnosis is not too difficult from a radiological point of view, but you may also see hypersensitivity pneumonia, either the chronic form or the inflammatory form in patients with connective tissue diseases. So this is always a differential diagnosis, and this is so important why we should sit together in these multidisciplinary team discussions to come up with a diagnosis. One cannot expect from rheumatologists or pulmonologists to know all the details in radiology, and we as radiologists have no idea, no clue on rheumatology. So it's so important that we sit together to discuss these cases, because these overlapping interests are there, and every one of us has their own specialities. What is BOOP is one question. BOOP is the old term for organizing pneumonia. That's what was formerly called. BOOP is now organizing pneumonia. Will antithesis syndrome have the same pattern as dermatomyositis or polymyositis? The answer is yes. And how can we differentiate GGO in pneumocystis, COVID-19, and connective tissue diseases? The answer is primarily the presentation. In connective tissue diseases, you have a chronic presentation. Patients have a progressive dyspnea over months and years, whereas COVID-19 as well as pneumocystis jirovecii pneumonia present with acute symptoms. COVID-19, we see a basal predominance, whereas in pneumocystis, it's more upper local predominance. That's the main answer here. Okay, I think we should stop here. I'd like to thank the organizers for having me. It was very interesting to me to get all these important questions from your side. But as mentioned earlier, this was a basic course. I'm sorry that I couldn't go into all of the more advanced questions you posed.
Thank you. Thank you so much for Professor Proch. Give us an excellent presentation. There will be a lot of information we should learn and about the CT scan, the pattern, the sign, and some different subtypes. And thank you again. But I noticed a lot of questions has been answered by Professor Roach. And before we move on, I want to take 1 or 2 minutes to briefly introduce AVR education webinar. Thank you for the APLA broad present Hark by Professor Danda, and also my teacher, Professor Xiaofeng Zeng, and especially care about the AVR. And Professor
So thank you very much again, Professor Prosh, for the nice presentation. So we are going to end the session, but before we end, we will tell you more about our upcoming events.
Okay, we have 2 things to announce. The first one is the AVR Blackboard, and we will make a similar with the NEGM case challenge. We'll make the challenging cues for focus on today's webinar, and you can scan scan from the screen and to answer the question. But for some technician, we will later send email of the question and the later things. And the next slide. Sorry, for next slide.
So we are going to have two more seminars next month as well. So one is on the echocardiography in pulmonary hypertension, something more than PASP by Dr. Kevin Gum from the Prince of Wales Hospital in Hong Kong. And the same session also, we have Professor Edmund Lau to talk about how to manage CTD PAH patients. Professor Edmund Lau is a professor from Australia. So you can register by scanning the QR code here. Also, please save the date for our coming APLA conference, the 23rd Asia Pacific League of Associations for Rheumatology Congress. It will be held in the August of 2021 in Kyoto.
Okay, thank you very much, everyone. I'd like to thank Professor Prosh again for his really excellent talk. And thank you, Lydia, and thank you, Professor Jill, for doing the chair for us today. And please, so now we come to an end of our webinars today. Please do fill in the evaluation form. When you end these sessions, there will be a pop-up link. So you just fill in for us so that we can improve on our future webinars. Thank you again. Not to forget to register for the next webinar that is on the 1st of May. So the topic, the theme is CTD PAH. We're having two excellent speakers, same as today. So we look forward very much in seeing you. Okay, so bye-bye.
Bye-bye. Thank you.
Bye-bye. Thank you very much.
Yeah. Goodbye.
Okay. So we are here, everyone.
Hi.
Yes, yes. So I think,
so
thank you so much, Prof. I think there's a bit of a connection problem with Zhu Liang.
I'm quite sorry about that. There are some
No problem.
my keys similar using the web line to do the lecture.